Welcome back to the deep dive. You're here because, well, you want to get up to speed on complex stuff fast.
Exactly. No wading through dense textbooks.
Just the essentials.
Yeah.
And today, we're tackling something called esophageal stricture.
Right. Think of it as a sudden fixed narrowing in the esophagus that's the tube carrying food down.
Caused by scar tissue, right? And it can cause a blockage.
Precisely. We've dug into the medical text, the details, and our goal here is simple.
Yeah, pull out the key info, what it is, what causes it.
How it's found, and crucially, what the options are. We want to give you those aha moments, but, without the overwhelm.
Okay, let's jump in. These benign esophageal strictures.
Yeah.
What's the story there?
So fundamentally, a benign stricture means the narrowing isn't cancerous. It usually stems from pretty severe inflammation, that's esophagitis.
Okay.
And it has to affect a large part of the esophagus wall, like more than 270 degrees around.
270.
Wow.
Yeah.
And there's often this cycle that gets set up.
A cycle? How does that work?
Well, the initial inflammation, the esophagitis, it can weaken the muscle at the bottom of the esophagus.
The LES, lower esophageal sphincter.
That's the one. It's like a gatekeeping stomach acid down. If it weakens, acid splashes back up more easily.
Making the esophagitis worse.
Exactly. And that ongoing inflammation tells the body, hey, repair this. But it does it by forming scar tissue.
Which causes the narrowing. Vicious cycle indeed.
It really can be. And it's worth remembering, actual cancerous strictures from tumors growing in, they're quite rare in dogs and cats, thankfully.
So the main hit is the digestive system, specifically the esophagus.
Primarily, yes. That's where the stricture forms. Sometimes there can even be more than one spot.
Mm-hmm.
But thinking bigger picture, the respiratory system can get involved too.
How so?
Because of regurgitation. If the animal brings food back up because of the blockage.
And inhales it.
Yes. If that happens, it can lead to aspiration pneumonia. That's when you'd see, coughing, maybe trouble breathing.
Sounds nasty. Is this something they're born with? Genetics?
No, there's no known genetic link for most strictures. And it's not super common overall, though obviously serious for the affected animal.
Any particular areas where it's more common?
There is one specific cause with a geographical tie-in, a parasite called Spirocerca lupi. Spirocerca lupi. It forms these inflammatory lumps, granulomas, in the esophagus, which can then cause strictures. You see this in the southern U.S., some parts of Europe, South Africa, Israel.
Okay.
But for the other causes, like reflux or pills, no real geographic pattern.
And does it affect certain breeds or sexes more?
Nope. Dogs and cats, males and females, any breed can potentially develop one.
But you mentioned something about young animals.
Ah, yes. Puppies and kittens born with a condition called a vascular ring anomaly.
Vascular ring.
It's where blood vessels form incorrectly around the esophagus, kind of trapping it. They often start showing signs like difficulty swallowing when they switch to solid food, at weaning.
Got it. So what should people be watching for? What are the actual signs?
Well, the signs usually get worse as the narrowing gets tighter. Early on, it might just be pain when swallowing. That's odonophagia.
Odonophagia.
And just general difficulty swallowing, dysphagia. You might also see more drooling than usual.
Increased salivation.
Right. And, of course, regurgitation.
Mm.
Bringing up undigested food pretty soon after eating. Not vomiting. Regurgitation.
Huge difference.
Huge difference. As it progresses, they might lose their appetite anorexia and start losing weight.
And we shouldn't forget the lung issue possibility.
Definitely not. If aspiration pneumonia sets in from the regurgitation, then you'll likely see coughing start, maybe panting, or difficulty breathing, which is dyspnea.
Okay, so what actually causes these benign ones? You mentioned reflux.
Reflux during anesthesia is a big one, probably the biggest. It accounts for something like 65% of cases.
65%. Wow. Why anesthesia?
Well, the theory is that some anesthetic drugs relax that LES muscle, that gate.
Letting acid come up.
Exactly. Allowing stomach acid to splash up and burn the esophagus lining. Also, severe foreign bodies stuck in the esophagus can do it.
Makes sense.
But usually only if the damage goes around most of the lining, that 270 degrees thing again. And here's a really key one for owners.
Yes.
Certain pills. Oral medications can cause esophagitis that leads to strictures.
Pills.
Really? Which ones?
Doxycycline is a common one, clindamycin too, and even aspirin.
Huh. So giving them the right way is crucial.
Absolutely critical. We'll come back to that. Other causes. Just regular reflux, not linked to anesthesia, Prolonged bouts of vomiting, swallowing something caustic.
Like cleaning products?
Potentially, yes. All those can lead to benign strictures. And then don't forget the rarer malignant ones, cancer. Usually squamous cell carcinoma or lymphoma.
Right. And the congenital one, the vascular ring.
And the infectious Spirocirca one we mentioned.
So tying it together, what are the main risk factors then? What makes it more likely? General anesthesia is definitely up there, especially if certain LES relaxing drugs are used or if the animal's tilted head down during the procedure.
Yeah.
And this is huge, giving pills or capsules without enough water, the dry swallow.
You mentioned that. How big a deal is it?
Studies have shown it's pretty shocking. Maybe 60 to 80% of capsules don't reach the stomach within 5 minutes if given dry.
80%?
Yeah.
Good grief. They just sit there.
Potentially irritating the esophagus lining? Yeah, it's a real eye-opener. And of course, swallowing foreign objects is always a risk factor for esophageal issues.
Okay, so let's say you suspect a stricture. How do you actually confirm it? What's the diagnostic path?
Well, first you have to think about what else it could be. Rule out the mimics.
The differential diagnoses.
Exactly. Things like metaesophagus, where the whole esophagus is dilated and flabby, or an actual foreign object still stuck. Or cancer, esophageal neoplasia, or something outside the esophagus pressing on it, like a mass or an abscess.
Right.
Or just plain old reflux, or vomiting from some other cause. Even problems starting higher up in the mouth or throat, oropharyngeal dysphagia.
Lots of possibilities. Do standard blood tests help narrow it down?
Usually no. Routine bloods and urine tests are often, well, pretty unremarkable for the stricture itself.
But maybe if there's pneumonia.
Ah, yes. If there's aspiration pneumonia secondary to the regurgitation, you might see signs of infection on the blood work, like high neutrophils, a type of white blood cell, but it doesn't point directly to the stricture.
So imaging is key.
Imaging is crucial, absolutely.
What kind are we talking? X-rays?
Chest x-rays, yeah. Thoracic radiographs, often the first step. They might look normal, honestly.
Unless there's pneumonia.
Unless there's pneumonia, or sometimes you might see the esophagus kind of ballooned out with gas just before the narrowed bit.
Okay.
But the gold standard, really, the preferred test, is a video fluoroscopic barium swallow.
Video fluoro. Sounds fancy. A moving X-ray.
Essentially, yes. The animal swallows barium contrast, and you watch on a live X-ray screen how it moves or doesn't move down the esophagus.
And if that's not available?
Then a regular barium swallow works too. Give liquid barium or paste or even food mixed with it, and then take quick X-ray pictures right after.
What does that show you?
It shows the narrowing, usually quite clearly an abrupt, tight spot. It often shows up best if you use something chunkier, like canned food mixed with the barium.
Right.
And you can see if there's more than one stricture. Plus, you might see that the esophagus above the stricture isn't contracting normally, which hints at that underlying esophagitis.
And location matters. You mentioned that earlier.
It can give clues, yeah. Strictures from reflux are often lower down, between the heart base and the diaphragm, pill-induced ones, often higher up near where the esophagus enters the chest, especially in cats.
Okay, X-rays give a good look.
What
about endoscopy, using a camera?
Definitely. Endoscopy lets you see it directly. You guide the scope down, and you'll see the sudden shrinking of the opening.
You can see the stricture itself.
You see the stricture, the lining, the mucosa. Usually looks okay, maybe a bit smooth. But if there's active esophagitis, it might look red and angry.
Can the scope get past it?
Often, no. Not without doing something to widen it first, like dilation. But the endoscope is key for diagnosis and for treatment planning. You measure how far down the stricture is from the teeth.
Do you need a biopsy? A tissue sample?
Usually not for a benign stricture, only really if you see something that looks like a mass makes you worry about cancer. Then yes, biopsy. Otherwise, the visual is usually enough.
All right, diagnosis confirmed, stricture identified. What's the game plan for treatment?
It really hinges on how severe it is. Mild cases, maybe outpatient. But if it's bad, causing malnutrition risk, aspiration risk, definitely needs inpatient hospital care.
Makes sense.
And also if there are complications like pneumonia or, heaven forbid, a tear in the esophagus, nursing care involves feeding soft, gruel-like food. Sometimes they need to be fed in an elevated position.
Like a Bailey chair for megasophagus.
Similar principle for milder cases, yeah. Keep gravity helping. If they're really dehydrated or can't eat, IV fluids are essential. Other meds depend on, is there esophagitis, other complications, what happens with dilation.
Inactivity. Keep them quiet.
Generally, yes. Mild restriction, especially right after a dilation procedure.
What about diet long-term? Or during treatment?
Gruel for mild cases initially. Often a low-fat diet is good, helps the stomach empty faster, less chance of reflux. After dilation, small, frequent meals of canned food usually.
Even if there was some tearing during dilation.
Yes, usually soft food is okay. Now, if the stricture keeps coming back, needing multiple dilations, then a PEG tube might be needed. That's a feeding tube directly into the stomach.
Percutaneous endoscopic gastrostomy.
That's the one. Lets you bypass the esophagus for feeding while you keep working on the stricture, ensures they get nutrition.
Sounds like it can be a long road potentially. What do owners need to know?
Client education is absolutely key here. They need to understand dilation isn't a magic bullet. It might take several sessions.
Right.
And sticking religiously to the post-dilation meds for esophagitis is so important to prevent it from just scarring back down.
Discouraging recurrence.
Exactly. The good news, most cases do respond well eventually. But if it keeps recurring after, say, 5, 6, 7, 8 attempts, then you start talking about other options, like stents.
And the outlook for cancer-related strictures.
Unfortunately, still quite poor. That's a different beast altogether.
Okay, let's focus on the main treatment, dilation. You've mentioned it a lot. Talk us through that.
Right. So mechanical dilation is the cornerstone of treating benign strictures, stretching it open.
How's that done?
Well, techniques have changed. Used to be rigid rods called bougies, then flexible bougies. Now balloon dilation is generally preferred.
Balloon dilation, why is that better?
The thinking is, though, we lack huge vet studies to prove it definitively that balloons apply force outwards, radially. Bougies can exert some force along the length of the esophagus, which might carry a slightly higher risk of perforation or tearing.
Okay, so how does the balloon thing work?
You use these specialized, strong plastic balloons. You guide them into the stricture using the endoscope.
So you can see what you're doing.
Precisely. Then you inflate the balloon slowly, carefully, up to a specific pressure rating. Can be up to 45 psi, quite high.
And you use bigger and bigger balloons.
Sequentially, yes. You gradually increase the balloon size until you achieve what feels like adequate stretching. It involves controlled microscopic tearing of the scar tissue.
Feels like.
It's subjective. In veterinary medicine, yeah, there's an element of feel and experience. And honestly, a lot of the specifics aren't nailed down by controlled studies yet.
Like what?
Like the exact sequence of balloon sizes, the perfect final diameter to aim for, whether injecting steroids helps, which post-op meds are best, the feeding plan, PEG tube use, how often to repeat dilations. Lots of variables.
But there must be some general guidelines.
Oh, sure. For the first dilation, you typically pick a balloon maybe 50 to 100% wider than you estimate the stricture is. If unsure, start smaller. Always safer.
And the final size?
Depends on the patient size, mostly. Rough guides might be cats and small dogs under 8 kilometers. Maybe aim for 12 millimeter, 15 kilometers, maybe 16 millimeter, up to 30 kilometers, 20 millimeters. Big dogs, 25 or 30 millimeter.
Millimeters in diameter.
Right. But it's always a balancing act. Get it open enough, but don't push so hard you cause a major tear or perforation.
You mentioned injecting steroids.
Yeah, sometimes triamcinolone, a corticosteroid, is injected into the stricture site during the endoscopy right before dilation. The idea is to reduce inflammation and scar tissue reformation.
Does it work?
Seems to help reduce the chance of restricture. Another drug, mitomycin C, applied topically during the procedure, can also be used for the same reason. Sometimes both are used.
And repeating the dilation. Do you do it electively?
There's some debate. Some vets like to do it weekly for a few weeks proactively. But given that most only need maybe 2 sessions total, the source material we reviewed suggests maybe waiting until you know you need a third one or if symptoms come back.
And if dilation keeps failing after, say, 5 to 8 tries?
Then you consider salvage procedures. A self-expanding metal stent, usually covered, placed across the stricture to hold it open.
Like a scaffold.
Exactly. But they need to be sutured in place surgically, or they tend to migrate. Actual surgical removal of the strictured section. That's really a last resort. Big surgery.
Okay. What about medications after dilation?
Sucralfate suspension is key. It coats the esophagus, helps soothe the inflammation, reduces pain.
Like a liquid bandage?
Sort of, yeah. And then meds to manage the underlying esophagitis are crucial. Cisapride helps tighten that LES and gets the stomach emptying.
Reducing reflux?
Right. And omeprazole, a proton pump inhibitor, drastically cuts down stomach acid production.
Better than older acid blockers?
Generally considered more effective than H2 blockers like famotidine, yes. And if there's aspiration pneumonia, of course, antibiotics are needed.
Anything to absolutely avoid.
Don't give drugs to make them vomit if you suspect a stricture or if it was caused by swallowing something caustic. And be cautious with dilation. Avoid being too aggressive. That's why sequential sizing is important.
Any drug interactions to watch for?
Sucralfate can interfere with absorbing other drugs, so you need to time the dosing carefully.
Are there alternatives if cisapride or omeprazole aren't options?
Metoclopramide can also help with stomach emptying and LES tone, but may be less effective than cisapride. And H2 blockers for acid, but again, omeprazole is usually preferred.
How about follow-up? What does that look like?
Close monitoring, watching for any return of signs, especially regurgitation, continuing the appropriate food consistency.
And deciding if another dilation is needed.
Based on those recurring symptoms, yes. And if pneumonia was present, monitoring breathing, maybe repeat x-rays to ensure it's clearing up.
Can we prevent these? What about that anesthesia risk?
Well, giving cisapride before anesthesia might help reduce reflux, but it's not routinely done everywhere. Giving omeprazole beforehand definitely can minimize acid damage if reflux occurs.
And the pills?
This is non-negotiable. Ulcer-causing meds, doxycycline, clindamycin, aspirin, must be followed by at least 6 milliliters of water, or ideally given with food. That wet swallow is paramount.
6 milliliters. That's more than just a drop.
It's a decent squirt from a syringe or a small meatball, something to properly wash it down.
Okay. What are the potential bumps in the road? Complications?
With dilation, the big risks are perforation, tearing a hole, or causing severe inflammation, or just having the stricture come right back.
And aspiration pneumonia again.
Still a risk if regurgitation continues. Stents have their own list. Migration, tissue growing over or into it causing blockage, food trapping, bleeding, perforation, pressing on the airway, tissue damage, fistulas, ongoing swallowing issues, pain.
Doesn't sound simple.
It's a salvage procedure for a reason. It carries risks.
So pulling it all together, what's the bottom line? The expected course, the prognosis?
Actually, for benign strictures treated with balloon dilation, the prognosis is pretty good. Success rates are often quoted in the 70 to 88% range for dogs and cats.
That's encouraging.
It is. Most need a median of about 2 dilations, can range from just 1 up to 5, sometimes even 8. Prognosis is generally worse if the stricture is very narrow or very old, chronic, and as you said, much poorer for cancer.
Okay, let's try and summarize this deep dive then. Key takeaways on esophageal strictures.
All right. There are narrowings, scar tissue blockages in the esophagus, lots of potential causes, but reflux under anesthesia and pills given incorrectly are really common triggers.
Diagnosis relies on seeing the signs and then using imaging, especially contrast x-rays or endoscopy.
And treatment is mainly about physically stretching it, open balloon dilation being the go-to, plus managing the inflammation with meds like sucralfate, cisapride, and omeprazole.
So for you listening, the big message is understanding the causes, recognizing signs.
And being really careful with how you give certain pills. That wet swallow thing, it matters.
It really does. And that makes you think, doesn't it?
What's that?
Well, if 60–80% of capsules might just sit there, if given dry, what other small, everyday things and how we care for our pets might have bigger consequences than we realize?
That's a fascinating thought. Definitely food for thought about being mindful of even the routine stuff.